Thank you, everybody, for joining this evening's webinar. We'll get going. Welcome. Tonight we will focus on endometriosis and fertility. My name is Ushma. I am the Engagement and Volunteer Manager at Endometriosis UK. And tonight I'm delighted to say we are joined by Dr. Sujata Gupta, who is a consultant gynecologist. Sujata will be introducing herself shortly, but specialist areas for yourself, Sujata, include minimal access surgery, including robotic surgery, treating advanced endometriosis, pelvic pain, heavy periods, and complex menopause. So it's lovely to have you here this evening. Just to let those attending know that the first part of tonight's webinar will include a presentation by Sujata. We'll then move into a Q&A section to answer a variety of questions that have been pre-submitted. The webinar is being recorded, just to let you know, and this also will be available on our website and YouTube page for those who cannot be here tonight. There is the live transcription, which is available. So you can enable live transcriptions by clicking on the CC button in the bar at the bottom of the screen. And also all guests will receive an optional feedback form, very likely to be tomorrow, by email. This is a chance for you to let us know your thoughts, give any suggestions and improvements for future webinars and topics as well. So without any further delay, I am going to pass over to Sujata. So over to you, Sujata. Thank you.
Thank you very much, Ushma, and thank you very much to Endometriosis UK for the opportunity to talk to you all today. So I will start sharing my screen. It says host disabled participant screen sharing, Ushma. Shall we try again? Yeah, okay, so I should be able to do it. Yeah, perfect. So I'm going to let me know if you can see it. I'll put in, yeah. So I'm hoping you all can see this. So as Ushma said, I'm Sujata Gupta. I am a consultant gynecologist and an expert in menopause and endometriosis, for which I use robotic surgery and laparoscopic surgery for some of the most complex endometriosis surgeries. And my NHS job is with the Manchester Foundation Trust. And I've been asked to talk about endometriosis and fertility. And I'm glad that this is something we are talking about, because one of the very first questions I get once somebody is diagnosed with endometriosis and I tell them that, you've got endometriosis, is the question of, would I be able to have a baby? And there's such a lot around this. So we'll spend next hour talking about this. But I would like to start by just talking a little bit about basics of endometriosis. So what is endometriosis? And most of us know it's a benign condition, which means not cancer, but patients with endometriosis will find that tissue which normally lines the lining of the womb is found outside of the womb, and that's not normal. Only patients with endometriosis will have that. And this tissue can be on the surface of the ovary, this can be on the surface of the pelvic cavity, this can sometimes be within the vagina. This can be sometimes on bowel or bladder, and sometimes in chest cavity, which is called thoracic endometriosis. If endometriosis is within the ovaries, it can sometimes make large cysts, which are called endometriomas, or we sometimes also use the term chocolate cysts, because it looks like these cysts are filled with chocolate sauce type material, which is essentially old blood. Endometriosis is a common condition. Unfortunately, despite being a common condition, it's not always diagnosed in a timely manner. So we still know that women on average wait for up to 8-9 years before getting a diagnosis of endometriosis. But it affects up to 1 in 10 women in the UK. That is how common it is. Where there is a family history of endometriosis, there's a higher chance that somebody will have endometriosis. Till this day, we do not know the exact cause for endometriosis, although we've got lots of theories, but none of them confirms exactly why somebody gets endometriosis and someone else doesn't. How do we know that somebody has endometriosis? So what are the symptoms to look out for? The commonest symptoms are usually extremely painful periods, to the point that you can't get on with your everyday work, you can't go to work, or you can't look after your family, or for younger girls, they are missing out on going to school or socializing with their friends. And the pain is usually typically cyclical. So it is more around the time of your periods. Sometimes it could be that it starts a few days before your periods. And that is quite common in most endometriosis patients. It can also sometimes manifest as pain during sex. And that again becomes an issue for somebody who's trying to get pregnant, and sometimes can become an issue within relationships where, because it hurts and someone does not want to have sex, would make the partner feel that relationship not okay, they're not appreciated. If endometriosis is affecting bowel, those patients will develop pain around the time of opening their bowels, sometimes usually around their periods, and sometimes these patients will see some cyclical bleeding through the back passage, again to tie in with the time of their month when they come on periods. Sometimes the pain during periods could be severe enough to cause sickness, and I certainly see patients who would come with a history of passing out or fainting, none of which is normal, but sadly a lot of them have been told, oh, it's just period associated pain. It's not normal to have that severity of pain associated with periods. Sometimes some patients will have none of these symptoms, and the first time they would think or come for a consultation is they are trying for a baby and finding that they're not getting pregnant, and sometimes it's picked up just like that. Sometimes if it's affecting bladder, again, there might be symptoms such as pain during passing urine, more so around periods, or sometimes blood in urine. Some of the symptoms which are not very clear but could be suggestive of endometriosis is just feeling tired. So chronic fatigue often is associated. And coughing blood is quite rare, but if it is a cyclical coughing blood, that would be suggestive of endometriosis within lungs, within thorax. So generally speaking, most patients would have that. Importantly, some patients with endometriosis will have no symptoms, and it is picked up just incidentally because they've had an ultrasound scan for some other reason, or they've had a laparoscopy for some other reason, and just by the by, we pick up lots of endometriosis. So it's quite an interesting and a tricky condition to diagnose, and it's also quite a tricky condition to manage. How do we diagnose endometriosis? So one is history. So I've talked about all those symptoms, and quite typically there is a lot more awareness of endometriosis, and patients will often come and say, I've got these symptoms, I've spoken to a friend, or I've watched your webinar, etc. I think I may have endometriosis. And your doctor should take a thorough history, and sometimes some symptoms are not volunteered, but if we ask specifically, does it hurt when you have sex? Does it hurt when you open your bowels? Then patients will sometimes volunteer that information. This should then follow by a thorough examination. And in examination, I'm talking about abdominal palpation, I'm talking about a pelvic examination, because often if there is severe endometriosis, it can sometimes present as nodules we can feel in the vagina. And by doing a pelvic examination, we might be able to pick up on those. We heavily rely on imaging for diagnosis of endometriosis. So this could be usually the first imaging is an ultrasound scan, which is a very good imaging to look at ovaries. Are there any cysts? is there any growth on the womb, etc. But sometimes we would want to do an MRI, and we would always want to do an MRI if there are symptoms of extensive endometriosis, such as bowel endometriosis or bladder endometriosis, or clinically on examination, it feels like there's quite a lot of disease. I've just highlighted this next bit because this next bit is there's a lot of research into endometriosis. After many years of no research, suddenly there's a lot of interest and a lot of research, and there are some new tests on the horizon. And these tests are not invasive, so they're certainly like not having a laparoscopy, which is surgery, and it could be a simple saliva test, which would give you a result in 4 weeks' time, which has a fairly good accuracy to say, yes, you've got endometriosis, or no, you don't. It's not yet available on the NHS, and last time I checked, even in private sector, it is currently not available, but it's something to keep an eye on, because in future it is possible that we might be able to pick up endometriosis with a simple urine test or a saliva test. So the gold standard for endometriosis for many, many years has been laparoscopy. And laparoscopy is a surgery done under general anesthetic, and it involves a small cut to belly button, usually, through which we can put a camera through. And this allows us to see the top of the uterus, the ovaries, the bowel, the bladder, and we can do a 360 check of your pelvic and abdominal cavity to see if there is any evidence of endometriosis anywhere else. So bowel, under the surface of your diaphragm, etc. And for many years, this has been considered gold standard. And the reason for that is if someone has very early superficial endometriosis, it will not show up on an ultrasound scan, and it will not show up on an MRI. So just because somebody's had normal scan, normal MRI, is not enough on its own to say you definitely do not have endometriosis. You possibly need a laparoscopy to be certain. The only other thing that has changed recently, according to the European guideline, is that we can use a trial of medical treatment, which is usually some form of hormonal treatment. And if by giving a course of hormonal tablets or injection, your pain completely disappears or your symptoms completely disappear, it is highly likely that this is endometriosis. So it's an indirect test of endometriosis. I've put a few extra here because we are talking about endometriosis and fertility. And one of the things we want to establish early on in someone who's got endometriosis and is trying to get pregnant is, what are the tubes like? Are the tubes blocked or are the tubes patent? And the reason for that is if the tubes are blocked, then there is no chance of spontaneous natural pregnancy, and this person is likely to need IVF treatment. So it's quite important to find that out early on. That's not the only thing. We would also do a range of blood tests to look at hormone levels, but a blood test which gives a good snapshot view of ovarian function is a blood test called anti-Mullerian hormone, or AMH blood test. And it just tells for that moment in time what is the state of your ovaries, how many follicles you have. It's not a predictive test, so having an AMH test today will not tell us what will be the state of ovaries in next 2 years or 5 years. So I'll talk a little bit about staging of endometriosis because this is extremely important when we talk about fertility. So stage 1 is described as minimal disease, where we would just see some tiny little spots of endometriosis on laparoscopy. And at this stage, you may not see anything on scans and MRIs. Stage 2 is when the implants are a little bit deeper and thicker, and you may see them on an MRI scan. But again, not necessarily. Stage 3 is moderate disease, where you start to see endometriosis in form of cysts on ovaries and also, again, bigger, thicker deposits. And stage 4 is when it is starting to invade into other organs. So for example, I've put a couple of pictures here. These are MRI pictures. On MRI scan here, this is bowel at the back, and this is a bit of endometriosis growing into bowel, and that would be a stage 4 disease. The second one is showing endometriosis getting into bladder. So here, this is bladder, and this is the womb, and there's endometriosis between bladder and womb. So these would be stage 4 disease. And stage 4, we almost always see it on MRI scan. Depends who is doing your MRI scan and who is reporting. So in my team, I work with a multidisciplinary team, and all of us are experts in endometriosis. So the consultant radiologist who I work with has expertise in endometriosis. The colorectal surgeon who I will be working with in cases like this also has experience and training in endometriosis. And likewise, for cases like this, we work with our consultant urologist who also know how to manage endometriosis from urology point of view. So it's extremely important to have that team of experienced people with experience of endometriosis, even though they are not gynecologists. This tells us a little bit about why is it important to understand staging and fertility in endometriosis. So this information is available on Endometriosis UK website. And if you look at this, and you'll see if somebody, so if we look at 100 individuals who do not have endometriosis and they start trying for a baby, about 80% will get pregnant within a year, and about 90% will get pregnant within 2 years of trying. Now compare this to somebody who has endometriosis. So if they have mild endometriosis, 75 will get pregnant within first 1 year, as opposed to 80. If they have moderate endometriosis, then only 50 out of 100 will get pregnant within first 1 year. Okay? And severe endometriosis may possibly, they may struggle to get pregnant at all, or the number will be a lot smaller. So people often wonder, how does endometriosis affect fertility? And I've seen some questions which have come in, which are around how does endometriosis affect fertility? So endometriosis can affect fertility by various means. It can affect, so if we look at this diagram here, and if we look at the ovaries, it can affect ovulation from the ovaries, either because there's a large cyst on the ovary, which is compressing the follicles, or it is full of old blood, which is again not a very healthy environment for the eggs to develop and mature. It can affect the tube by simply blocking the tubes, or sometimes causing kinking on the tubes, because endometriosis causes lots of inflammation, lots of adhesions, so it can affect tubal function. It creates a very toxic environment within the pelvis. And often, because of that, a sperm may not survive the journey, and sometimes the inflammatory response will not let pregnancy implant properly. So for all those reasons, pregnancy rates are lower. What we also need to keep in mind is if somebody does manage to get pregnant, they run a slightly higher risk of miscarriages and ectopic pregnancy. Miscarriages, again, because the environment within which the pregnancy is trying to establish is not healthy, and there's lots of inflammation, and that could cause miscarriage. Or in ectopic pregnancy, if a tube is damaged, then when the journey with the early pregnancy is made to the back of the womb, that journey might not take place all the way back to the womb because the tube is kinked or blocked, and so a high risk of ectopic pregnancy. So what do we do? How do we manage this? How do we treat endometriosis? So I'm mostly going to focus on fertility, But we can't just talk about fertility without pain, because often patients with endometriosis will come with both of these two issues. So we will talk about everything, but with focus on fertility. So one option could be, so like I said, non-endometriosis patients will get pregnant within first 1 year. And sometimes some patients would want to give a bit of time and say, well, my preference is to get pregnant, and maybe I want to try for pregnancy. And just because somebody's got endometriosis does not mean that they cannot try for natural conception. But my advice would be that not to keep on trying. So normal guideline would be try for 1 year or even try for 2 years. But if you know you have endometriosis, or if you have symptoms that sound like endometriosis, my advice would be try for 6 months. And if things are not happening, see your GP and you'll need onward referral. Same advice goes for somebody who's age 36 and over, because we know that fertility declines significantly once you are past 35. So for those reasons, I definitely say do not try for 1 whole year before you ask for help. Yeah. And I'll talk about treatment options around endometriosis now. So we have medical treatment options and we have surgical treatment options. Now, I've not written much about medical treatment option here because a lot of medical treatment options involve hormones, which is not something we would recommend to someone who's trying to get pregnant, because they're often hormonal pills or injections or coil, and all of which is not suitable, contraindicated for someone who's trying to get pregnant. So hence, I've not said much. You can use simple pain relief, paracetamol, ibuprofen, things like that, but anything hormonal is a no-no. So we'll talk about surgery. Now, who should have surgery? Surgery is always taken into account considering overall symptoms. So if somebody has a lot of pain, sometimes that might be a reason enough to have surgery. But we also need to be mindful if someone is coming, and I often ask them, what is number one priority for you? It sometimes feels like quite a mean question to ask, because often it might be that I want my pain to go away and I also want to have a baby. But sometimes we need that clarity to decide what to do first. Should we do surgery first? Should we think about IVF first? And hence, often it's a much detailed discussion around what are the symptoms, how old is the patient, what is their preference, is there any history of previous surgery with endometriosis. I will talk a little bit about endometriosis fertility index in a bit, but all the other bits, what are the ovarian reserve? And one must not forget, pregnancy is always with male factors and female factors. So or in certain conditions, we may not consider male factors directly, but we do need to be mindful that we've assessed the semen analysis, etc. So I'm not going to talk about that throughout my talk because I'm assuming that is okay. So we'll focus here on the person with endometriosis. Now, keeping all of that into account, surgery in the form of laparoscopy to remove endometriosis has good outcome for somebody who wants to try and achieve natural pregnancy for early stage disease. So multiple papers have proven that if you have early stage endometriosis and you have laparoscopy and removal of endometriosis, your chances of conceiving improves certainly within next 2 years of your surgery. And this is for if you are to try naturally to conceive. And this might be very useful to someone who is maybe wanting to try naturally, does not want to go for IVF, or someone who's not eligible for IVF, which many patients are. The next thing to consider is that a clinician may consider laparoscopy if there is a large cyst on the ovary. And sometimes that will get in the way of IVF treatment, because for IVF, people need to be able to access the ovaries to get the eggs, and sometimes they can't do that. So that would be another reason to consider surgery. And lastly, there is no compelling evidence for someone who has deep endometriosis that having surgery will improve your chances of getting pregnant, but we would do that because somebody is in significant amount of pain. So we would take into consideration the whole picture. This is just a simple diagram to show what do we mean by stages of endometriosis. So I've tried to define it earlier, but we use this kind of diagram to just show that in very early stages, there's few tiny little spots. The next one, again, those spots are getting a bit bigger. The next one, we are starting to see small cysts on the ovary. The next one, we are again seeing cysts on the ovary, but perhaps some adhesions affecting the tube. The following one, we are possibly seeing more adhesions and possibly touching onto the bowel. And the final one, it's basically everything is just clumped up together, the bowel, the ovary, the tubes, everything. So that's just to give you an idea. And we've used this for many, many years to stage endometriosis. Now, again, one interesting thing with endometriosis is that somebody with very early mild endometriosis may have lots of symptoms, and someone with advanced stage endometriosis may have no symptoms. So the correlation between how bad your symptoms are and the stage of the endometriosis might not make sense, but a lot of things about endometriosis do not make sense. This is a scoring system. So this is how we document where did we see endometriosis, and then we add up all the points to decide whether you're stage 1, 2, 3, 4. This is something far more interesting from fertility point of view, and this is endometriosis fertility index. And what this includes is the scoring system that I've already discussed, but it also includes other factors such as age, how long somebody's been trying for a baby, have they had any previous pregnancies, etc. And it also specifically looks at what is the state of fallopian tubes, what do the ovaries look like, because you may have mild endometriosis, but if your fallopian tubes are blocked, then we know at the start that you possibly need IVF. But it's very useful to have this, because if rest of everything looks good, then your chance of actually having successful IVF is pretty good. So this scoring helps us decide, following surgery, which are the patients who have a better chance of IVF success and which are the patients who have not so great chance of success with IVF. And so generally speaking, once we've done the calculation, if the endometriosis fertility score is more than 6, they tend to do better with IVF treatment, and if score is less than 5, they tend to do, they tend to struggle, and their success is not as good. So, it's just, it's just a few numbers, but there's a lot of detail in individual patient. Medically assisted reproduction, so I've talked about that decision to offer surgery to remove endometriosis before starting IVF, there isn't a strong evidence one way or the other. And usually we are guided by symptoms. And often patients would say, I'm in that much pain that I need surgery to help with my pain. If the question is, I need surgery and will this help with my IVF, the evidence is not very clear on that. So if there are no pain symptoms and someone wants to go for fertility treatment, we wouldn't necessarily say you have to have this surgery before you go on to having your IVF treatment. There are some papers which have said it helps, but overall convincing evidence is lacking. I'm going to talk a little bit about fertility preservation, and this comes in the context of somebody who comes in for surgery for endometriosis, but would like to preserve fertility options, for example, would like to preserve ovaries, would like to preserve a womb, with the view that they may want to try for a baby. Now, endometriosis surgery can sometimes be extensive, with extensive surgery on the ovaries. And sometimes that runs a risk of causing damage to the ovaries to the point where we do not have enough eggs left to be able to use it. And all those discussions need to be part of a discussion when we talk about surgery with endometriosis. And I'm sure there are questions which we will discuss on this later on. So the other question that is asked a lot is, what is the impact of endometriosis on pregnancy once somebody gets pregnant? So I've mentioned that there's a slightly higher risk of miscarriages in ectopic pregnancy. If somebody has a cyst on the ovary and they get pregnant, then those cysts can look a bit different during pregnancy, and sometimes it causes some concern and some alarm, and sometimes that would mean that those patients will be asked to have some extra scans. It's not unusual. It's not a reason to not get pregnant or to not try and get pregnant, but it's just to mention that if you have an endometrioma, you'll need a few extra scans during your pregnancy. Endometriosis on the whole suppresses symptoms of endometriosis. So on the whole, the pain gets better. And for that reason, erroneously in the past, patients have been told to go and get pregnant. That is completely the wrong thing to do. And we no longer advise that, and I hope nobody does that. But what we know is pregnancy helps with the pain associated with endometriosis for most patients. For some patients, it doesn't, because if these patients in a small subgroup, if they have had lots of chronic scarring as a result of endometriosis, they may actually have more pain due to stretching at the time of pregnancy. And sometimes the scarring because of endometriosis would be severe enough to make any surgery during pregnancy complicated. I certainly know of cases where cesarean sections have been complicated because of previous endometriosis. And sometimes a gynecologist like myself would have to go in and help our obstetric colleagues to do that cesarean section. So it's quite important to be mindful of those. And if somebody's got endometriosis, especially advanced endometriosis, and they've had multiple surgeries, it's quite important to tell your midwife and your doctor at the start of your pregnancy about this. And lastly, something which gets forgotten about with endometriosis is menopause. And menopause affects patients with endometriosis, young and old, severely, because sometimes some of the medical treatment for endometriosis is GnRH analog injections, which induce medical menopause, and those patients are sometimes not given HRT or will be given HRT for a number of years. Surgical treatment is sometimes, as I mentioned, multiple surgeries on ovaries will bring on earlier menopause, or if somebody's had total hysterectomy, they might enter early menopause, and early menopause has significant implications on overall health. Natural menopause. So some women were told, just wait for your menopause, and once you go through menopause, everything will be fine. And for a lot of them, yes, from endometriosis point of view, things are better. They don't have monthly pain. But from menopause point of view, things are not great because now they have problems of menopause. And it's quite important to know that in patients with history of endometriosis, menopause is managed slightly differently. So, we would always talk about combination of estrogen and progesterone, whether you have a womb or not. So it's just to be mindful that menopause and endometriosis is a specialist area, and you need a specialist input into that. And premature menopause, unfortunately, is not uncommon with patients with endometriosis. So these are some of the references for information that I have included in my talk. And this is my final slide. And take-home message, I would think, from today is most patients with endometriosis can conceive naturally, because this is possibly one of the first things I tell somebody who's newly diagnosed with endometriosis. If someone thinks they have endometriosis or they're diagnosed with endometriosis and they're trying to get pregnant, if nothing is happening within 6 months, please see your doctor. Medical treatment has very limited role. Surgery improves spontaneous pregnancy in early stage endometriosis, but there is less convincing evidence for IVF. Surgery should be considered if somebody is in significant pain, and don't forget menopause. So that's the final slide. And this is just a question. This is a picture of my BSG fellow members. So I'm a member of British Society of Gynae and I'm a council member. And every year we do a charity cycling event to raise money for Endometriosis UK. So I'll stop sharing my slide and I will take any questions. Let me just find how to stop sharing my slide. Just a second.
Wonderful. Thank you for that, Sujata.
Okay. Stop share. So yeah, hopefully that's happened. Okay.
Yep, it's all done. Thank you. So
Okay.
we've had some pre-submitted questions.
Yeah.
So we'll start to go through some of those, and if there's time, we'll pick out some of those questions that have come in through the live Q&A. So we've got a question here. How would you suggest someone dealing with the return of endometriosis symptoms and struggling to conceive?
Yeah, so that's sadly not an uncommon situation because, as we know, there's no cure for endometriosis and it can come back. I would go back to, some of the things I've already said in the slide. So we need to take into account, how old are you? What is your previous fertility history? Um, has tubal patency been assessed? What is the ovarian function? So all those questions we would have to revisit to see where we are. So sadly, not a very straightforward answer, but I think if I try to answer your question briefly, we need to take into account your tubal function, your ovarian function. We need to take into account, the semen analysis or where the sperm's coming from, and we need to take into account what does it look like. So when you say symptoms have recurred, I would think as a minimum you should have a scan, and that will give us more information on what's the state of things. Is there a large cyst, in which case is there a case for further surgery, or do we decide actually because of this and that reason we need to go straight to IVF?
Thank you. We've had somebody else ask, is there a best course of treatment to protect fertility?
Again, a tricky one, okay? I think so. The best course of treatment, in my opinion, is first of all early diagnosis, because unless you know you've got endometriosis, there's very little you're doing about it. And although we don't know natural progression of endometriosis, logic would say if nothing's being done, your endometriosis is likely going to deteriorate. So if we suspect endometriosis early on, then whether it's a medical treatment or surgical treatment, but we should be talking about something that stops progressing endometriosis to further advanced stage. So yeah, I think quick diagnosis, early diagnosis, talk about treatments. Both are fine if you're not planning on getting pregnant immediately. So medical treatment is fine because you're not planning on getting pregnant immediately, and it's a case of discussing pros and cons of both.
Thank you. We've had somebody ask, how do you go about getting support through the NHS for fertility?
Okay, so I'm guessing this is coming from somebody who has concerns about endometriosis.
Mm.
So the first thing I would say is ask for help early on. If you're being told, oh, you haven't tried for a year or you haven't tried for a 2 year, just say that I have endometriosis, or I suspect I have endometriosis, and I have been told if I don't manage to conceive within 6 months of trying, then I need to be seen and referred. And following that, you should have some basic tests to look at your hormone levels, an ultrasound scan, etc., and semen analysis. And from then on, you'll be referred on to a specialist if need be. But my main thing here is ask for an early referral.
Thank you. We've had somebody asks, so they have stage 4 endometriosis. What can they do to support themselves to get pregnant?
So, like I said, that just because you've got stage 4 endometriosis does not automatically mean that you have to have surgery. We would consider surgery if you had significant pain and pain was your priority. In the absence of that, if you've tried to conceive yourself, because again, you can try naturally because some patients will, but if you've already done that and it's not happening, then we would say the usual things: get your tubes checked early on, get your ovarian reserve checked early on, and those are usually not very complicated tests. They can be done, and that will then help you decide whether you want to go down the route of IVF. Now, again, if somebody is in their 20s, then you could say, you could try for another year or two, etc. But my advice would be very different to somebody who is 35 or 36.
Mm.
So there's a lot of detail to it, but hopefully, hopefully some of the questions are clear here. Yeah.
Thank you. So we've had somebody else ask, they're nervous about coming off the hormonal treatments and the endometriosis symptoms returning. Are there ways of managing this without hormones? And I know you've touched on it in your talk, but
Yeah. Again, a very common scenario because, yes, when you don't want to have a baby, you can go on medical treatment, you can be on hormone tablets, but then comes a point when you want to start trying for a baby, but the fear, the minute you come off your tablets, will your symptoms come back? My advice in that situation would be, you don't know. Okay, so there's a possibility if you've been on it for a number of years, your endometriosis is suppressed, and maybe once you come off it, if you do manage to get pregnant, quickly, you possibly may not suffer the symptoms of pain, etc., etc. So my advice would be if you're planning to have a baby, come off it and see how you go. You do need help and support throughout. So in my trust, we have wonderful endometriosis nurses who are always on the phone. And if there's any problem, you pick up the phone and you speak to them, and they will give you advice, or they'll book you for a clinic consultation. And often it's a case of, if your pain comes back and if it's severe, we may want to see you. We may want to do a scan to see what's going on. So you will be under a close observation and follow up to see how you cope. So you're not on your own. But I would say, yes, if you want to try, you have to stop your medical treatment and see how it goes.
thank you. So we've had somebody ask about adenomyosis as well, and they've asked, how does this affect someone's fertility and chances, and is it different to what you've discussed today with endometriosis?
So not a lot different. Okay, so adenomyosis, I think one of my patients described it, and I quite liked her description. Adenomyosis, the way she said it, is endometriosis of the womb. And I thought that's a very good way of putting it, because if you go to my very first slide about what is endometriosis, it is presence of the lining of the womb like tissue outside of womb. Adenomyosis is where we see this tissue, which should be within the lining of the womb. We start to see it within the muscle of the womb. And as a result, the whole womb feels very inflamed and sore and achy. And adenomyosis affects fertility in almost similar ways as endometriosis. One of the shortcomings of the endometriosis fertility index is it does not look at things like adenomyosis, but we know that patients with adenomyosis are at a higher risk of struggling to get pregnant, higher risk of miscarriages. So in terms of how it affects fertility, it's very similar to endometriosis.
We've had somebody else ask, they've been told that they possibly have endometriosis with severe pain when they were younger, but now they're struggling with perimenopause. What would be the next steps that you would advise around that?
So I would say it is important to get your diagnosis right. Okay. The reason for that being a couple of things really. Let me just take a step back. if you have perimenopause and if you're thinking about some sort of help, let's say HRT, yeah, just because you've had possibility of endometriosis does not mean that you can't use HRT. What is important to bear in mind is that with endometriosis, bleeding generally aggravates endometriosis. So, all the things that we have in terms of medical management, we try and minimize the number of bleeds a person has. So, the type of HRT for perimenopause is usually a cyclical HRT where you have a monthly bleed. And if you have history of endometriosis or a suggestion of endometriosis, monthly bleed might not be the best thing. So the type of HRT where you don't have any bleeding, which is called a continuous combined HRT, is a better form of HRT for you. The other thing to keep in mind is if somebody has history of endometriosis and they do not have a womb, so they've had a hysterectomy. Now, normally, somebody who does not have a womb will go on estrogen only HRT because they don't have a womb, they don't need progesterone in their HRT. Endometriosis is an exception where we would still want somebody on estrogen and progesterone HRT. So there are those two differences to keep in mind. So patients with endometriosis can, of course, use HRT, but it's important to realize that there are slight differences in how we prescribe HRT.
Thank you. I'm just having a quick look. So somebody's asked if endometriosis is left untreated because the pain is manageable, can it spread to a level that is dangerous or harmful to other organs?
So this is again a very common question and a very common concern. The reality is we don't know, okay? Because what we see is some patients will present with advanced endometriosis very early on. And some patients will have early stage endometriosis and it will stay early stage endometriosis for many, many years. So the most honest, the honest answer for this question is nobody knows. However, logic would say that if we know somebody's got severe endometriosis, I personally feel better monitoring these patients. So I have patients who choose not to have surgery because they are managing their symptoms, and I tend to see them at least with once a year scan, so I can keep an eye on things. But there's no guideline on this. We all pretty much use our common sense and logic and say, okay, fine, we'll just keep an eye on things.
Okay. We've had somebody ask, do you have any tips on how to physically prepare for IVF to help improve success rates?
So it's usual lifestyle advice. Okay, so it's about healthy weight, healthy eating, quit smoking if anybody smokes, because those are huge factors for IVF success rate. Making sure that I'm just trying to think what folic acid supplements if you're trying to get pregnant. Yeah. So it's just optimizing your health, making sure your alcohol intake is within advisable limits. So the best physical health that you can be in is what's advisable. The other thing to consider is if we always like to make sure that you have immunity for certain conditions like rubella, etc., etc. So it's good to have all that checked beforehand before you get onto the journey. And most IVF units will do that. So most IVF units will usually send you a form to fill in, which asks for all these questions. A lot of IVF units do not take referrals if BMI is above a certain cutoff, if people are still smoking, and those are the reasons because those have significant impact on IVF success rate.
And we've had somebody ask, they have suspected endometriosis, which didn't show up on scans,
Mm,
but the symptoms of which are now being successfully managed with the Marina coil.
yeah.
Should they consider the exploratory surgery to confirm diagnosis and remove endometriosis before trying for a baby?
Again, so a very interesting question. So, one of my slide mentioned how do we diagnose endometriosis? And like I said, for many years we took laparoscopy as gold standard. So if scans are normal, does not mean you don't have endometriosis. And laparoscopy will show you if there's endometriosis, where it is, and how much of that is there. We no longer say that that's the only way to diagnose endometriosis, because if you've tried a medical treatment and your symptoms are better, chances are you have endometriosis. So in your case, you've tried Mirena and it's helped, which tells me you have endometriosis. So you could you could do either. You could have the coil out and try for a baby and give it 6 months. And if you get pregnant, then you don't have to worry about anything. Um, on the other hand, if you don't get pregnant, then that would be a time where you need a proper thorough assessment, and possibly that would be a time for a laparoscopy. So that's one way. The other way is sometimes patients really want to know, what is it? It's not on scan, but do I have it, where it is? And sometimes when patients really want to know at the start, that is an acceptable option in my opinion. So you could choose to do both.
Thank you. We've got a couple of minutes left, so I'm going to try and get through as many questions as we can. So we've had somebody ask, how is it possible to manage pain during pregnancy? And will the endometriosis pain be affected by being pregnant?
It's quite rare in my opinion.
Mm.
So most patients with endometriosis actually feel better because their pain is suppressed, which is why people used to say, oh, just get pregnant kind of thing. Very few patients who have severe endometriosis and possibly have had multiple surgeries will struggle. And we often work with pain specialists because during pregnancy we are limited by what type of pain relief we can offer. So we would often work with pain specialists in those cases to try and minimize pain. We sometimes, depending on how things are, we may sometimes even think about an earlier delivery. I certainly have, one case where we decided that once we were at a point where baby would have a good outcome, we decided to cut short pregnancy duration by a few weeks. So it's on a case-to-case basis, but usually it's a rare thing, but does happen.
Thank you. I know that in your talk you talked, at the end you mentioned kind of the takeaway home kind of message, and I'm just very aware that we're coming close to 8 o'clock really, and we will be kind of wrapping up. But just kind of wanted to go back to that point and just kind of, if we could ask you to sum up in terms of kind of what we've covered today, could you kind of take a few moments to do that?
Of course. So I think the first thing is telling someone you have endometriosis is has a huge impact because it's a chronic condition and most people know that there's no cure. And one of the most significant worries that I get often asked about is, will I be able to have a baby? So my advice would be most patients with endometriosis can get pregnant and can have babies. The ones that struggle should seek help sooner, quicker. So certainly within 6 months of trying to conceive. If things are not happening, then please go and see your GP.
Wonderful. Um, Thank you so much, Sujata, for the talk today. Sadly, that's all we kind of have time for today. It's been such an interesting webinar, and thank you for answering as many questions as we possibly could.